working at a pharmaceutical company in Pensacola, Florida. We make, and you may or may not know this, we're a tiny company. We make Proin, phenylpropidone, for little girl dogs that inappropriately urinate in the house. So, any equine surgeons. I am going to talk to you about fluid therapy. I've been assigned the task of talking about fluid therapy, some surgical items as far as pharmacology, and if I understand and remember it correctly, y'all are in the process. Feel free to raise your hand and ask a question as we work through this. These lectures should not take a full 2 hours, so we'll kind of ease into it after your mental workout this morning. So some general comments as you guys start preparing for surgery, and I tell this to every class that I teach these lectures to, and the first and most important thing you need to do is find a theme song for yourself, because when you go out and practice and you're doing surgery, especially when you're a young practitioner, it's scary, and if you aren't doing surgery running anesthesia, it's equally as scary. So I would challenge you to start listening to songs, finding one that really represents something that can help you get psyched up to go into surgery. So as you graduate or go into your training, that you have something that you can listen to prior to walking into the OR to really find confidence. That's my practice tip for today. Other people say profound quotes, and I say go find a song that makes you feel pretty. Animal that 60% of their body weight is composed of total body water. A neonate is 70%. So when we talk about where drugs go in neonates and what they're exposed to, remember that their total body water is significantly higher than that of an adult animal. Extracellular fluid accounts for about 20% of their body weight, and then intracellular fluid is equal to the total body weight minus the extracellular fluid. And so depending on if you're talking about an adult, it'll comprise about 20%, and then a neonate will be about 10%. So fluid electrolyte distribution, I promise you there is a test question on this particular slide, because it's very important for you as clinicians to know where the electrolytes are, or when you get a sample, what you're actually appreciating and where things there can be things hiding. So in your extracellular fluid volume, sodium is the primary cation for extracellular osmolality. When you get a sample from the blood, that is a pretty good indicator of the extracellular sodium that is present in the body. In contrast to that, the primary cation for intracellular osmolality is potassium. So it should make sense to you if the patient's whole body potassium is low, then probably the intracellular potassium is also very low. And that's going to be something on your levels that when you start to look at more clinical pathology, you're going to appreciate that indicators both of potassium elevation or decrease are going to be things that you have to pay very close attention to. Also, correcting potassium deficits, as I'm sure you guys have learned, is a lot more dicey than correcting sodium deficits. The primary pump that is responsible for keeping these cations in balance is the sodium-potassium ATPase pump. It maintains the balance of sodium outside the cell, and then the balance of potassium inside the cell. Again, spent a lot of time on this slide, promise you there is a test question that is on that slide. I also try to tell you guys as we work through this, because I'm a big fan of y'all have enough information to plow through. I should at least help guide you to where some of the most important things are. I also tend to ask pretty clinically based questions. I don't expect you guys to reinvent the wheel, but I do expect you guys to be good practitioners when you come out. So, physical signs of dehydration. I think in your anesthesia or your surgery lab, you have probably covered this, but we'll just do it briefly here for the sake of pharmacology. Anything less than 4% dehydrated, you're probably not going to pick up on clinically when you're doing a physical exam. Bless you. 5 to 6%, you might start to pick up some of the subtleties such as a dull hair coat, mucous membranes that are slightly dry. There might be a subtle loss of skin elasticity depending on where you're testing it. 7 to 8 is probably clinically where we start to see some things that we can pick up on, and then we can start addressing. Delay in return to the skin to normal, so skin tinting, their tongue may be dry and the mucous membranes as well. Their eyes may be soft and sunken, or there might be a slight prolongation of your capillary refill time. So all of y'all are probably about 7 to 8 right now, I would probably guess, based on your examination this morning. When we get to 9 to 11%, the skin does not return to normal, very prolonged CRT, sunken eyes, all mucous membranes are dry, and then they start to have signs of cardiovascular compromise, such as tachycardia, cool extremities, rapid and weak pulses. And hopefully, you will be able to start treatment intervention before 12 to 15, where there's definite signs of shock and circulatory collapse. Keeping in mind that basically anything less than 4 you won't be able to detect, and 12 to 15 is imminent death. All right, so we're going to talk about some practical aspects of fluid therapy. The purpose of fluid therapy is very, very basic, and if you can understand the purpose of why you're doing it, it's going to help you determine to select a product to do it and how to administer it. First and foremost, the reason why we select fluids is for dehydration. Another reason may be because there's an electrolyte imbalance, and gosh forbid that we sit here and talk about acid-base abnormalities in clinical clin-path. Do you guys have to do cases where you have to, yeah? It's good to see that they're still torturing students with that. The treatment of shock, as well as parenteral nourishment, and then to stimulate organ function. Again, if you look over here at these slides, you'll see that the cations found in extracellular fluid are sodium, and then in intracellular fluid is potassium. So you should start to be putting in place that if these are where they're found, we are going to have to replace not only sodium, but also potassium. When we look at the anions, and we don't talk a lot about anions, but it starts to make sense when we talk about fluid selection, that with every cation, there's probably an associated anion that goes with it. So chloride you can see, as well as bicarbonate, and then phosphate over here. So fluid therapy diagnosis. Number one, as a clinician, you're going to do a physical exam. So the nature of the color of the mucous membranes will help you a lot. This is just an example of what gums should look like. They should be nice and pink and moist, and you can even tell from the picture that they're glistening. They should not look like this, where they're so pale and tacky, and they definitely shouldn't be brick red and dry. So appropriately assessing your mucous membranes should help to give you an inclination of how systemically supported the patient is. Skin turgor will help you assess, again, trying to check the box where in the percent dehydration the patient is. Then it comes down to questions to ask the client. And you don't think about this as a young practitioner because you're worried about whether or not you stuck the thermometer in the right orifice, or is that really the heart rate? Why is the dog panting? But then as you progress and you become less scared of being a doctor, you realize that there are certain questions you should ask. So number one is duration and frequency of vomiting and diarrhea. Has this been going on for hours? Has it been going on for days? Has it been going on for weeks? And all of that, as a clinician, should start painting a picture in your head as far as whether or not this is a subtle thing, whether or not it's, if it's a long duration, how many other deficits do you think you're going to have to supplement, especially if it's profound vomiting and diarrhea, you're going to have to think about electrolytes as well as if it's been a long duration. Consistency of stools, depending on how observant your owner is, will tell you whether or not, the dog has had anywhere from, a soft feces all the way out to watery diarrhea. And some clients may not know. They let the dog out in the backyard and have no recollection of what it's doing until it made a mess inside. Fluid and dietary intake, asking them whether or not, the dog is aggressively eating, aggressively drinking, excessively drinking. Urination, frequency of urination, whether or not the animal keeps asking to go outside, if there is more puddles in the house, if they're having accidents, are they not urinating at all, as well as the color of urine. I can tell you I have 2 dogs, and I couldn't tell you what color their urine is because just don't. But there are some owners that have fluffy that will tell you all the kinds of the descriptions. My grandmother is running with them, and I'm so glad I'm not a small animal vet or her vet, because she will call her vet about 4 times a week to give them updates on various parts of Whitey's anatomy, and I'm like, whoo, that's why I did horses. So that, as well as the presence of character or thirst. So blood work will be our guiding light as far as fluid administration, remembering that when patients are dehydrated, both the hematocrit as well as the plasma protein will be elevated. So it makes sense when you initiate fluid therapy, you'd want to monitor that periodically, depending on your clinical expertise and what practice you are in, to see that drop down to a more normal level. Depending on what the other underlying conditions the patient has, you might also want to look at its blood gases, so looking at PO2 and PCO2. When we talk about anesthesia in a little bit, we will go painstakingly into PO2 and PCO2, as well as base excess, bicarb, and total CO2. Electrolytes, you will also need to monitor depending on whether or not you are supplementing or if the animal is having vomiting or diarrhea. And finally, BUN and creatinine. Just as a reminder, here on the right, when we are treating dehydration or when an animal has dehydration, normal kidneys in response to dehydration, the specific gravity will increase, the urine volume will decrease, and the treatment would be to, you would initiate, both of those would decrease after, the specific gravity will decrease after initiation of treatment. This is not a ClinPath course, so I won't go into it, but just so you know, as far as your analysis, things that you would be looking for or observing. All right, so we'll move into fluid administration. So as we move through this lecture, we're going to touch on some of these questions that should help you take a practical approach to fluid therapy. Number 1, when to give fluids. So most of the time what we are going to be doing is replacing some sort of fluid deficit. And there are 3 steps to doing this that are going to be clinically important. Number 1, you need to assess whatever existing deficit that patient has. So you do this by assessing their hydration. So going back up to the chart above and figuring out what % dehydrated you're going to determine. That allows you to calculate the animal's replacement volume. So the body weight in kilograms times the % dehydration. Probably an important point to know. It's a very simple equation, very simple math, but an important concept for you to know as a practitioner. Step 2 is that you need to satisfy the maintenance needs of the patient. So this is needed when patients do not voluntarily ingest sufficient food or water to replace their normal losses. Remember, even while you're sitting here in class, your body is losing fluids, either through just everyday functioning. So you cannot, once you assess how much they have lost, you also have to calculate in what they need for basic requirements. So an adult animal needs between 40 to 65 mils per kg per 24 hours. A neonate, on the other hand, because remember they have a higher metabolic rate, will need 130 mils per kg per 24 hours. The third concept, after correcting the existing loss, satisfying maintenance, is also to replace ongoing losses. And you as veterinary students, when you hit the clinic, at some point will have to do fun things like quantifying how much vomit or diarrhea or urine that your patient has lost. And then you're going to have to go back through and do these calculations. So remember that when patients are sick, they're going to continually have these abnormalities. So you need to categorize and include increased amount or frequency, and then provide a clinical assessment. You will be estimating the volume, and then you will have to add it to the maintenance levels. Remember that when animals are profoundly sick, either vomiting, diarrhea, or polyuria, the fluids that you may be putting in, you are forever going to be behind until you can almost get them over when you have to get them over what they are losing. And so if you do not do a good job estimating the continued ongoing losses, you will never get on top of that patient's hydration, and they will continue to be compromised. So accurately estimating how much they are losing in ongoing losses is very important. In horses, for example, there are cases where you have to put in 2 catheters in order to keep up with their losses, which is usually a poor prognosis for that particular animal. So what type of fluids? We're going to talk about replacement fluids first. Remember that replacement fluids should reflect the composition of the volume that is being lost. And so that should make some common sense. You wouldn't want to pick to replace a body fluid. If an animal has vomiting and diarrhea, you wouldn't want to pick a blood product. So having an idea of what's being lost and the nature of the fluid that is being lost. So in GI tract, the loss of vomiting and diarrhea, there's going to be a loss of electrolyte-rich fluids. And so you want to select a fluid replacement composition that is representative of those electrolytes, so sodium, potassium, chloride, as well as bicarbonate. If you have blood loss, such as an animal that's been hit by a car or an equine, a uterine artery rupture, the whole blood volume has disappeared either into the body cavity or outside of the animal. And so your replacement fluid then you're going to choose is going to be, whole blood to restore the circulating blood volume. So having an idea of what you're losing so you can correctly pick. Keeping in mind that what you're losing also needs to have an idea about what electrolytes are being lost as well. So there are replacement fluids and maintenance fluids, and depending on what practice you go in, they may have both, but more than likely they're going to have one. And because it's just easier to stock and it's more economical to stock. Most of the time, your practices will have maintenance fluids. Maintenance fluids are different than replacement because they can be used to replace fluid deficits, but they're lower in composition as far as with sodium and higher in potassium. So if you don't have replacement fluids, you can make a maintenance fluid into a replacement, but you need to calculate and supplement with the appropriate electrolytes. Always make sure that, especially with potassium, you are ensuring a proper dose to your patient, otherwise you could get in big trouble and cause toxicity. So when you start in a practice, either in private practice or if you're an intern, just take a look or ask someone if you're not sure what kind of fluids you have so you have an idea in your mind as a practitioner what you're dealing with. So how much fluid? The rate of fluid administration. So the rate of administration, this is underlined, so I would recommend that this is probably an important statement for you to commit to memory. The rate of administration and electrolyte supplementation parallels the severity of dehydration and deficits. Does that make sense to everyone? So if you have an animal that is severely compromised, you're probably going to be pretty aggressive with fluid therapy. However, if you have an animal that's just coming in and it's a little bit dehydrated because maybe mom's a little bit over observant, you're probably not going to powerhouse some fluids to it. So common sense topic, but just keep in mind that your fluid rate should match the severity of clinical signs in the patient. In most scenarios, fluids are administered rapidly at first and then decrease the rates until a condition is corrected. And many times this is going to be monitored by you or your technical staff, depending on how big the practice is, but you're going to do periodic physical exams to look for changes in the patient's physical exam signs that show that the patient is becoming more stabilized, but as well as doing like a PCV, total solids, to see how well you are perfusing that patient. So shock rate fluids, moderate dehydration will be between 15 and 30 mils per kg per hour. Also, especially in small animals, you want to be very careful that you don't overhydrate the patient with blood, patient causing pulmonary edema. Severe dehydration, you may get up to 50 to 90 mils per kg per hour. And this is where you will use aggressive fluid administration where it's appropriate. So different fluid rates, both require you to be on your game as a clinician and to monitor. So how do we give fluids? So the route of administration depends on a lot of things. Number one is the type of illness, the severity of the condition that the animal is in, the degree of dehydration. So typically where this gets in a little bit more of a gray area is if the patient is only like 5 to 6% dehydrated, maybe the patient doesn't have, or the client doesn't have a lot of money, they don't want to hospitalize it. This is where you might start thinking about whether or not you're going to do IV fluids, or are you going to do sub-Q fluids, those type of things. Patient condition will be very straightforward when the patient is very compromised, but again, in a little bit of those gray areas, it's going to be up to you in your clinical assessment. Keep in mind, as a young practitioner, you're going to step on both sides of light. Sometimes you're going to guess right, and sometimes you're going to guess wrong, but that's okay, and that's how you build your practice experience. Also, the type of electrolyte imbalance, depending on how severe the electrolyte imbalance is, and obviously if it's a potassium imbalance, it can be a whole lot different than if it's a sodium one. The time and equipment available, again, depending on where you guys want to practice and what capabilities your practice has. Not many private practices have the capability to run IV fluids all night long, but if you're in a specialty practice, you will, so you're going to have to tailor accordingly. So the route of fluid administration, oral or nasogastric, this is the least dangerous way to give it. You don't have to worry about tonicity, volume, or maintaining asepsis. You can use a variety of different combinations of electrolyte salts, glycine, and dextrose to administer. It's very beneficial when you're giving oral fluids to do some sort of dextrose solution if you can, because when you ensure that you are providing some sort of nutrition to the lining of the epithelium in the GI tract, helps keep those cells nice and healthy. Remember, when animals get compromised, they don't just have decreased blood flow to their extremities, it's to everything that's not pertinent to sustaining life. So that includes their GI tract. And so if they don't have blood flow down there, then those cells are compromised and they slough off, and then you have exposure of the GI contents into the bloodstream. That didn't make sense to me until I was well into my residency, like, oh, okay. But I might have been slower than y'all, but it made sense to as I was practicing. Rectal fluids are good for young animals that may be difficult to get an IV on, and you can use combinations of warm water, potassium, sodium, and chloride. The thing to remind yourself is if a small, tiny animal has the diarrhea, rectal administration is probably not going to be the way to go. So common sense, however, at 3 a.m. when you're a new practitioner and you're freaking out, anything can happen. So just keep in mind, if there is GI distress back there, probably not the route to choose. I say that because sometimes common sense is lost on people, because when I was a surgery resident, my favorite was I got a call at 3 a.m. from a student, and they were freaked out because the horse passed some white manure. And I was like, well, what happened 2 hours? It was like, well, I gave it metronidazole rectally. And I was like, probably why the manure is white. It's okay, or those early hours in the morning are a little bit difficult for everyone. So how to give fluids? Parental routes include IV, sub-Q, as well as intraperitoneal. We forget about intraperitoneal, those of you that are going into the pocket pets or the zoo animals or exotics, that is a route that is commonly used. Remember that IP, intraperitoneal, is very similar to IV fluids. We don't usually do it in small animals, but it is a route you can administer. Remember that those fluids, if you are going to be injecting it in an animal, they need to be sterile in nature. That should make pretty sense, that you don't want to inject something that's not sterile and create an abscess. So IV fluids, we'll start working through the parental routes. IV fluids need to be isotonic. We'll talk briefly in a little bit about hypertonic formulations, but keeping an eye on what their tonicity is is something we will have to address. Problems associated with use, maintaining asepsis during catheter placement or injection. So placement of catheters can be an issue, especially in sick animals that clot, or just animals in general that rip their catheters out. You can have clotting issues that prevent you from placing a catheter, as well as hematomas, so animals that are a little bit fractious to catheter placement. Large volumes given too rapidly may overload the circulatory system. Remember that these patients, you're trying to restore their circulating blood volume, but if you don't do it at the rate that the body can support, you can compromise the patient. It's a very finite balance. And obviously I would be remiss if I didn't say it can also cause death, which is super scary to say for IV fluids. All right, so sub-Q administration. This is a very convenient and a used for correction mild to moderate deficits in small animals. Very young or very small animals, this may be the only route that you have available. It might be, the animal might be difficult to restrain for IV administration, and so this is the best route you can do. It is absorbed more slowly than if administered by IV. And in this particular case, unlike intravenous administration, you can only give an isotonic fluid. You should not ever give hypertonic. Fluids, you also need to avoid fluids containing dextrose or ones without electrolytes. This can affect, if you think about it, when going back to the first slide, if you were to do either one of these, you can affect the diffusion of electrolytes into the area and cause severe reactions. Because remember, by putting a substantial amount of fluids in the sub-Q space, you're creating a depot of liquid, and if it's not balanced to the body, there will be significant fluid shifts and compromise your patient. Issues with sub-Q injection can be edema of areas that inhibit absorption, so that any particular abnormalities that don't allow the body to bring that fluid from the sub-Q space into the intravenous space. Cold fluids will not be absorbed, so you need to warm them to body temperature to facilitate rapid absorption. So intraperitoneal, these fluids are mobilized faster than sub-Q. They have the same restrictions as IV as well as sub-Q. So important I put it twice. The risks for this is the development of peritonitis, secondary injection, as well as puncture of viscera. So again, if you are looking to do this in whatever species, just make sure that if you have an ultrasound, you can do an ultrasound guided and make sure that you're not in a viscera. Obviously, if you put your needle on there and wait a hot minute, you will tell if you are in a viscera, I promise you. All right, so we can keep, do you guys need a break, or if we keep trucking, you can have a longer break? Yes. I was hoping you would say that. Am I going okay for you guys?
Yes.
Okay. All right, so we're going to talk about the different types of fluids. And as a student, it was very hard for me to keep them separate for whatever reason. So we're going to talk about crystalloids, colloids, blood replacements, and then we'll briefly, just as a note, you guys need to know that there are nutritional solutions, but I'll keep those intricacies to people far smarter than me to talk to you about amino and fat emulsions. All right, so crystalloids are replacement fluids, balanced electrolyte solutions. Most commonly, your crystalloids are going to be used for pre and post-surgical support. So your spays, your neuters, your elective procedures may also be the fluid that you reach for treating diarrhea and vomiting. Patients that come into your practice that need to have an aminoglycoside, you guys just got done with antimicrobials, right? Bless y'all's heart. Remember that aminoglycosides can cause renal toxicity, and so if you're going to treat with them, and especially if you're at all worried, you're going to have to admit patients for IV fluids while they're on treatment. Trauma as well as shock can be an indicator. They're typically a balanced electrolyte solution that resemble the extracellular fluid volume. So if we remember from the first two slides, that means that they will have an innate high sodium level and a low potassium level. Things that you should know. So in any of your crystalloid fluid bags, they're polyionic, which means that there's just lots of different ions present. Commercial products will vary in amount of each ion, but they are designed to assist in the delivery to the specific spaces that they are targeting. The key points of using a crystalloid is the fact that once they are given in the vein, they don't stay there. Okay, they rapidly diffuse out into the tissue. So as much as you put that in, you can figure that it's probably in the circulating blood volume, maybe 5 to 10 minutes, and it's already out in the tissue. So then that's why that little picture there is like Puff, the magic unicorn, is gone. So just because you are administering fluids, you're not administering to the circulating blood volume because it's gone. Does that make sense to everybody? That being said, because we know that when you administer these replacement fluids or balanced electrolytes, you are going to have to give a large volume at a rapid rate to treat patients that are in shock. And it should make sense to everyone in those tiny patients or the patients that are vascularly compromised, overloading them with a bunch of fluids, especially crystallites, could get your patient in trouble. And this is usually why we have to shift into another fluid type. Reestablishing these particular fluids, though, are really good at reestablishing effective perfusion without altering electrolyte concentrations, which is one of their strong points, but just know that you're going to have to give a large volume. There are alkalizing bits, so there's portions where there's substrates that are in those fluids that are metabolized into alkalizing equivalents that help correct non-respiratory acidemia. So the liver will break down the lactate to help facilitate that, muscle will break down acetate, and the whole body will break down gluconate. All of those will break down into products that help combat the respiratory acidemia. Keeping in mind, when you give a crystalloid, you should never administer it with calcium-containing solutions. So never administer it in the same port as whole blood or sodium bicarbonate, because crystals will form. So when we talk about crystalloids, most commonly we're talking about normal saline and LRS, as well as plasmolite. So when we talk about normal saline, remember that normal saline is just sodium and chloride, that's it. There are specific situations when you will be choosing saline over another product. Saline has acidifying solution portions, and that's used to treat patients with metabolic alkalosis. This particular saline is high in chloride. This promotes renal excretion of bicarbonate, so it really helps with those patients that have a high bicarbonate level in their bloodstream. Normal saline, if you were to be asked on the exam, is used to treat hyperkalemia, because remember some of these other crystalloids have a may have a higher potassium content, and if your patient has hyperkalemia already, you do not want to make that worse. It also is used to treat hyperkalemia. So remember, some of like the LRS or the plasmolite will also have a significant level of calcium, and you may not want that in your patient if they're hyperkalemic. And then when we talk about, I'm not sure if Dr. Judd's already talked to you about diabetes, but if you have a patient that is in a ketoacidotic state, you would want to select a normal saline over another product. So important reasons why to pick that particular bag of fluids over another one. Yes, ma'am.
Sorry, what does DKA stand for?
Diabetic ketoacidosis.
Thank you.
So the second class of crystalloids are known as the hypertonic saline solutions, or HSS. In equine practice, these are usually plastic 1 liter jugs that are kept off to the side. In small animal practice, it's probably a similar, maybe probably a less volume. This particular solution is, remember, it's hypertonic, so it's going to be much more, have a higher tonicity than your regular crystalloid solution. This is used for patients who are experiencing shock associated with hemorrhage. Those patients that have had severe trauma, or those patients for small animals that have had a GDV. Anything that you need to restore circulating blood volume quickly. So you are putting something into the bloodstream that has high tonicity, so it's going to suck all the fluid out of the extracellular space into the bloodstream. But in patients that are severely compromised, you're basically robbing Peter to pay Paul. You are pulling all of the fluid that's already in the patient in the bloodstream to keep the heart and the blood vessels pumping, to keep all those organs alive, but in the same respect, you are depleting any sort of fluids that you had out in the tissues. And so the circulating sodium attracts water into the vasculature from the interstitial space, helps restore the capillary flow as well as tissue perfusion. The dose is there, 6 to 10 mils per kg. And I believe this is on the next slide. What results when you give this to patients is an increased cardio output due to decreased preload. Does that make sense to everybody? So when you're failing when you are failing and you don't have enough circulating blood volume, you don't have enough preload, the heart becomes traumatized, you give hypertonic saline, it pulls all that water in, pulls everything back into the vasculature, increases cardiac outflow, increases preload, helps the body for short term kind of get jump started. So this particular product is very short-lived. It peaks occurs usually in about an hour. The effects may be prolonged if you combine this treatment with colloids and crystalloids. So the first important thing you need to remember is this never gets used by itself. So you can use it as a very aggressive acute phase treatment, but you better have a fluid plan for what you're going to do afterwards. It is contraindicated, and this should make sense in patients that come in and are hypernatremic, right? Because you were about to give them can't say that word, a lot of sodium, and so you, if you don't look at your blood work when you first come in and you get your initial assessment, don't give them as a hypernatremic patients. You get them maybe in more trouble. Also, you don't want to use it with patients with increased plasma osmolality, meaning if they have some sort of protein abnormality that they're circulating, that's very uncommon. And then do not use alone in dehydrated patients. This one, I can't harp on enough. Yes, ma'am.
Would you use this in a hypertensive patient?
No, so it depends on what the underlying cause of hypertension was, and what, how bad it was for that particular patient. I would be very careful using it, but I would want to know what the underlying reason is to why. Yes, sir.
Can this also be used as an acute, so if you have like an acute increase in intracranial pressure due to cerebral edema, we've used this before to almost as a mannitol substitute?
Yeah. No, that's good. That sounds like a very surgeon way to approach that. Yes. The only importance that, for you as practitioners is just to know you cannot use this by self. As in, this is going to only give you about an hour, and you can't give this and then ship the animal off 2 hours to go to a referral hospital. You can give this to help stabilize, but you better have a bag hanging on that patient on the way, because if they have a long transport time, your patient will be even more compromised when they get there. So making smart decisions as far as that goes. So colloids is the last group that third group that we will talk about. Colloids are used to balance the force that draws water into the capillaries with the hydrostatic pressure pushing the water out into the tissues. And if you remember from, gosh, that's probably first year somewhere, those are called the Starling forces. I love how you're like, yes. Yes, that was a very strong affirmative from you guys. So albumin is the primary force, primary protein that is responsible for helping maintain this. When this becomes a problem is when you have dogs that have like a protein losing enteropathy, and so they might be not making albumin or they're losing it. And remember, they can lose albumin 2 different ways, out their GI tract, or they can lose it out their kidneys. And so when you look at that piece of blood work, as much as it pains me as a surgeon to say, look at blood work, when you look at that, assessing where your albumin is going to be very important, because remember, if you don't have a substantial amount of albumin to hold the fluid into your bloodstream, you can give all the fluid you want, and that is not staying there, it's going right out into the tissues. And so in these particular patients, you're going to be treating ones that are not capable of holding the fluid into their bloodstream, and so you're going to choose something like a colloid. So colloid fluids contain large particles should be called probably proteins, that are retained within the vascular space. These are given in a lot smaller volumes, and they cause a greater volume expansion. And so everyone always tells me that the SAS is strong with this one, including my boss in Florida that's probably enjoying the day off for me today, that I get to impart it with you. So these are small, sassy molecules that hold in the fluids in the bloodstream. The duration of effect is very variable depending on the species, depending on the dose, depending on what product you use, whether or not you have a pre-infusion intravascular volume, which means have you already been, as the animal, already been on fluids, as well as the microvascular permeability, meaning if that animal's really sick and it's already leaking out of their microvasculature, the effects of colloids is going to be very different than if an animal isn't quite as complex. give this bag of head of starch, and then the animal will be cured. This will medication for you. So if they are not to be, if there are blood component deficiencies, or if there is a disease that leads to response or trauma, and the body begins to shut down and you get the SIRS effect or the multi-organ dysfunction syndrome. The body starts to work against itself. These are things that you are going to have to reach for to really pull it in and treat it. There are natural as well as synthetic types of colloids. So the natural types of colloids that we most commonly think of is whole blood. We usually in our practice will think of using whole blood when there's whole blood loss. Plasma, for those of you that are going out into especially surgical practices, plasma only does plasma have albumin. It also has all the clotting factors and all the good small proteins to help maintain those microvasculature in a more healthy environment. It also has albumin. Synthetic products that you're probably used to picking up off the counter wherever you practice, Dextran 4, Dextran 70, hetastarch and pentastarch, and the differences in the names is usually due to the weight or how large that protein is. So Dextran 40 is probably going to be smaller than the Dextran 70. Hetastarch is going to be smaller than pentastarch, just based on the configuration of the protein. Again, when you start at a practice, be it an internship or a private practice, spend some time looking at these fluids so that you know what you have. And then if you are capable of, and you don't, or you have some suggestions, make those so that you can make your practice experience as easy as possible. So monitoring, along with the other types of fluids, close monitoring with these guys is going to be even more important. Help to reestablish the vascular integrity, so you still need crystalloids with colloids to replenish the interstitial as well as intracellular fluid deficits. So what that means is that colloids are simply giving the proteins to keep the fluid in the vasculature. You have done nothing to actually restore hydration to the rest of the body. You've basically just equipped the bloodstream to hold it in there and to keep it in there to support the heart, but and also to support the fusion out to the tissues. So this is just one modal of treatment modality that you have, but they should not be used again like hypertonic alone. Adverse events, you should know in cats, there have been documented anaphylactic reactions in cats, so be very careful when you administer them. Monitor closely to prevent intravascular overload and interstitial edema. Keep in mind if you are monitoring a patient and you decide to treat with a colloid, initially you're going to have to drop back your crystalloid therapy. Does that make sense to everyone? Because if they're going to start to draw some of that fluid in, there's going to be some shifts. So if you drop down your crystalloid therapy a little bit, let that colloid come on board, assess your patient, and then you can increase accordingly. The last thing you want to do is to overwhelm your patient or with fluid therapy. So closely monitoring the perfusion. Remember the perfusion is monitored by mucous membranes, feeling of their limbs, skin tint, those type of things. Monitor their hydration with PCV total protein, as well as colloid oncotic pressure. Most of your general practices, you're probably not going to be rolling out monitoring colloid oncotic pressure, but in specialty practices that you might be doing that depending on where your interest lies. So whole blood and plasma administration. These are pictures of, this is a carotid artery rupture in a horse. This is a uterine artery rupture in a horse, just showing you a picture of it. This is a horse, but it can also be present in a dog, just hemoabdomen. And this is one of my favorites, is when a horse has a nosebleed and then turns it into a horror movie. So whole blood, there's a variety of different reasons that you could have whole blood loss. Anemia, so acute or immune-mediated cause it. Blood loss, hemorrhage due to an artery rupture. That will be an indicator of administration of whole blood. Plasma, most commonly we're going to reach for plasma in a situation where you are hyperproteinemic. This can be due to vomiting, diarrhea, or most commonly sepsis in your patients. Keeping in mind, when you are going to do a whole blood transfusion, you want to do cross matches for your patients, so both major, minor, or both, depending on what your practice does or what your comfort level is. When you are administering plasma, no cross match is required, so those are pretty straightforward for you to do. In a lot of cases, you may be able to, if the patient is borderline, in some cases, if they're not able to afford a whole blood transfusion, depending on the underlying pathology, plasma may be a good option. But again, that depends on what the patient is affected with. Administration, so when you're administering either whole blood or plasma, you have to calculate the amount necessary to give. Remember that when you give a transfusion, you're only going to increase the hematocrit 2 to 4% for the next 24 to 48 hours. So it is a life-saving activity. However, on your blood work, it's not going to show a drastic significant increase. Anytime you are giving whole blood or plasma, you want to administer slowly for the first 20 minutes and then increase the rate over time. So monitor the patient closely for signs of anaphylaxis. So increased heart rate, respiratory rate, formation of hives, elevated temperature. There are now blood substitutes. Oxyglobin is one of those. Indications for use would be blood loss or anemia. And these contain purified hemoglobin that have removed the red blood cells and suspended it in solution. This is used when red blood cells aren't available. Various practices may or may not have it, depending on what their feelings are or what their clientele, what you see. Solutions can pass through the microcirculation more readily than red blood cells. Remember that when microcirculatory system, when it gets compromised and inflamed, instead of being nice and smooth, it's very jagged and it's hard for red blood cells to get through, and then you have issues as far as pooling and clotting. So these solutions can pass nice and easily through the microcirculation. It's ideal for acute hemorrhage or poor blood flow. Oxyglobin is the only product approved for use at this time in veterinary patients. It's derived from bovine hemoglobin. The dose rate is similar to what we talked about before with hypertonic, with 10 ml per kg per hour for one dose, and it does not need to be cross-matched, which makes it a really, really nice product for those of you going out into emergency and critical care. Is probably where you're going to see a product like this. All right, do you guys have any questions? Good. So I am done for today for the fluid administration. I guess the next time I see you is next Monday, and I will send, is it okay if I send the email to the class president and you'll forward it up? Okay, I will send your lectures that way, and I am sorry that